I'm Dr. Lisa Sammaritano, rheumatologist at the Hospital for Special Surgery. I am the lead investigator on the ACR Lupus Nephritis Treatment Guideline. The ACR has put together new treatment recommendations for lupus nephritis. This is updated from our last guideline, which was published in 2012. And it is dramatically different because there has been a great deal of research and new drugs that have been approved over those years. This guideline differs from our previous guideline from the American College of Rheumatology in that we are incorporating these new medications, and that includes belimumab as well as voclosporin. Many people are familiar with standard therapy for lupus nephritis, and that has been for many years now either cyclophosphamide, which is an intravenous medicine, or more recently, mycophenolate, which is an oral medication. And both of these combinations of drugs with steroids do work to bring about remission in a certain proportion of patients with lupus nephritis, but they don't bring remission to 100% of patients. We call this triple therapy, and the three components are steroids, because we still do need to use steroids in this treatment of lupus nephritis at the onset, either mycophenolate or cyclophosphamide, and then combination of either belimumab or voclosporin with one of those. In this guideline, we propose giving IV steroids followed by a more moderate dose with a rapid taper, so that our goal is to be on 5 milligrams of prednisone or less at the 6-month mark, rather than continuing on high doses for months. We recommend treatment with this triple therapy for 3 to 5 years from the time of diagnosis. Why is that? Well, we know from studies that it takes a long time for the inflammation to come under control. Even when the protein in the urine is better, even when the labs look better, there's often some residual inflammation in the kidney. And if we stop treatment before that, there's a greater risk of flare. The goal of this guideline with our multiple recommendations is to preserve kidney function so that we can minimize complications from kidney disease, and also to minimize complications from the medications. This treatment guideline for lupus nephritis is meant to be the starting point of a discussion between a rheumatologist and a person with lupus nephritis. It is meant to give the evidence to tell both the rheumatologist and the patient what's available, how well it works, what's better in certain situations. But there are so many individual factors for any given person with lupus nephritis that it is imperative that the patient and the physician have a discussion. We do plan to revise this regularly, every several years at least, so that as new medications are approved, as new literature comes out, they will still be up to date and relevant and useful for practicing physicians.